Good afternoon, and thank you for joining the Quality Payment Program, QPP serves with hybrid solutions. My name is Phoebe Nelms, and presenting today will be Liz Hanson. We'll be discussing MIPS tips, what to do to be ready since half of this reporting year is already gone. As usual, we have upcoming virtual learning opportunities. We are going to take a very brief siesta from or should I say hiatus from our webinars, our virtual office hour in August, and we'll be back with you in September to discuss the security risk assessment. And we'll also let you know what our next general topic will be for our webinar. Today's topics, we will cover 2021 scores, the QPP 2022 checklist, the exception application options, and success tips for this year. We'll also review a few frequently asked questions and share the resources that this material comes from. And so without further ado, I will turn it over to the lovely, talented, and beautiful Liz Hanson.
Thank you, Phoebe. My goodness, that was worth getting up for. Many of you may be thinking that you've heard this topic before. As a matter of fact, you may be thinking you heard it in May, and you heard it in February, and you heard it in December. And it is similar to the same things that we have covered over the last several months and half a year. But every month we continue to learn something, whether it be a nuance to a measure or CMS interpretation that we read on an FAQ, or an interim rule that's come out, or a surprise for something we didn't know they were going to audit for, and they started auditing for, or some changes to the Harp. So we learn something. I find that I learn something every week, and it continues to amaze me. So our hope is that we can share that with you at least once a month. And if there's some other areas that you want to discuss, even if we're not super familiar with them, if it has to do with healthcare information technology, we'll see if we can't get a subject matter expert to talk to us about it. And we'd love to have your questions. So, and we're recording this so other folks can come back and take a look at it. I know it's summer, so we didn't expect a big turnout today, but we appreciate you taking a look at this information and hope that you learn at least one thing today, or there's something that you can share with us that we can learn.
I love the way you framed that, because it does seem the same, but as you pointed out, there are so many things to keep track of that having a reminder can save you a lot of headache. Just that one little thing save a lot of headache moving forward. So thank you so much for keeping your finger on the pulse.
That's very true, Phoebe. And I have to tell you that just yesterday, I saw something new. Okay, so things change, and if we know about it and we can share it with everybody, then maybe it'll be less of a barrier, or not cause as much stress, or just give some relief. So we want to share, and we want to hear what other folks have to share as well. So first, we want to talk about the 2021 scores, because we've had a little bit of a different process this year. In the past, you knew that hopefully you got to see preliminary scores, and you checked boxes saying you understood they were preliminary scores. And you're used to seeing those sometimes when you submitted your attestation, sometimes not until April, or May, but you're used to seeing those pretty close to the end or the closeout of the attestation period. And then you're used to seeing final scores in July, and then having until perhaps till October to do a targeted review if there's something seems off about the results. But this year we've got it a little different. Apparently in the last few weeks, I don't think I saw it until last week, Phoebe, you might have seen it sooner. They've changed up the way they're doing it. Oh, maybe it was 2 weeks ago.
Yeah, I think so.
Yeah, they mentioned it on a CMS webinar, And I was just shocked because I had no idea they were going to do it that way. I mean, it wasn't terrible shocking, but I was very surprised that they're posting these semifinal scores, but they're not really final scores. But if you don't, and you have to check a box again saying you know they're not final scores, even though it reads that they're the final score. But if there's an issue with them, you're supposed to call attention to that and move forward with that. Although the final scores aren't due out until the end of August. So what the net of this is check your 2021 scores. Oh, another thing is QPP looks a little different than it did a couple months ago. It's kind of funny because when everybody first starts logging in, they usually miss that agree signature on that first page. It was just a little box you had to check, and a lot of people miss it the first time, but after about the third time, everybody's got it. Well, they've now made that a pop-up. So even if you were one of those thousands of people that remembered to check that box, now you got to deal with a pop-up as well. So that's kind of irritating. I don't know quite why they did that, but maybe it's helping somebody, so that's okay. But we 2 months ago or a month ago, you could get in and out of QPP. You could reset your password. You didn't have to call in. And then within the last 3 weeks, it started being hard to get back in again. Now, the net of this is get into your QPP account through Harp. And it tells you have to reset your password, then reset your password. But it tells you need to call them, then call them and get it reset. Don't wait. Please, please, please don't wait. If you look at your scores and they look totally out of whack, then you need to call the QPP support line and talk to them about it. Don't wait. Do it now. Because if they do an announcement in the next month and say, okay, that was your targeted review period, so hopefully everybody's got it resolved before the finals come out in August, it's going to be a zoo. So or the last day of August or something to that effect. So don't wait, get it done. Make sure you understand what's going on. If you're one of the folks that work with us, then call us and let us get involved in working through what's going on. Again, the final scores are available in August. In the past, once the final scores became available, then you then had a reasonable amount of time, maybe 90 days to do a targeted review. Okay, maybe 60 days. But I don't know quite what the rule is going to be and when the deadline for the targeted review process is going to occur. And if anybody, Phoebe, if you've heard anything else, please let us know. But otherwise, we'll just wait for announcements with telling everybody to go check it. Anything?
No, I haven't heard anything additional, but I did try to call the help desk yesterday, and if you need to call them, set some time aside because it was quite a long wait. So definitely don't want to wait till the last minute if you need their help.
Oh, I hate to hear that. But on the good side, I would like to draw your attention of something that I snipped from one of the folks we work with yesterday, because I was so delighted to see their score that I asked them if I could take a little snapshot of it and share it. So I just wanted you to see that somebody did make a 95.91 for 2021. I'm really proud of them, and you can do it, and it wasn't easy. So with that said, I just wanted to let you know it can happen, and they worked real hard, and they listened to most of our tips. So I hope this helps you as well. There we go. So what should you be doing in 22? Well, just like we've told you before, you need to stay the course, but you might want to speed up because we're coming around that summer curve and going into the home stretch. And now is not the time to wait. As a matter of fact, sometimes it might be a little slower around your office in the summer. It might be time for you to get those workflows straightened out. So let's talk about what should we be doing. First, let's go over the performance threshold, because I need to make this perfectly clear. The threshold, the minimum goal, is 75 points. Folks, there was a time when that was above the exceptional provider amount, okay? And now it's the minimum. What does that mean? It means that it's getting harder to get a higher score. Well, no, it means that you got to make a higher score to not get penalized. And why is that harder? It's harder because so many of the measures have gotten tighter, and it's not as easier to get as high a score. So them changing it to 75 points is not what makes it hard. I shouldn't have said it that way. And personally, I feel like it's the quality issue that's making it hard. But we're going to talk about that too. So CMS used, they didn't just say, hey, let's just slap 75 on it. They used some science, some math to it to determine, as per legislation, what the performance threshold was going to be and what the exceptional threshold was going to be. And they probably leaned towards the providers in this, but the net of it is the exceptional threshold is now 89 points. And that's pretty serious. So with that said, minimum is hit 75. And if you can't hit 75, get the highest score possible. Payment adjustments will occur, which will occur in 2023, can be up to plus or minus 9%. Now, we've never seen a full positive anything, I don't think.
No, never.
Yeah,
And I think you meant to say 2024.
I did. I'm sorry. I did mean to say 2024. Thank you so much. We don't expect to see a positive 9%, but we do expect to see some higher numbers than in the past because we think more people will fail and will have to participate this year. We've had 2 years where we've basically given a free pass. And I'm afraid that just made it harder for folks to catch up. But now you got to pay the piper, unless there's a reason for you to get another free pass. And that's okay too. But don't stop working on this so that when you do have to participate, you're lost and can't catch up. All right. I do want to mention that 2022 is the last performance year with the payout in 2024. It's the final year for the additional performance thresholds. So this is the last year to take advantage of some of the things that are going to be available for small practices. So, okay. So now I've talked about what the potential is. I've said it could be anywhere from plus or minus 9%. But many times I talk with folks who think that if they have, for instance, a 74, they're going to get a minus 9. Okay. 74 is 1 point below passing. You are not going to be penalized a minus 9 for that. Now, I can't tell you exactly what you are going to get penalized, but I can share with you this published chart. If you're greater than or equal to 89 points, then you are eligible for an additional payment because you're an exceptional performer with a minimum of 0.5%. Hopefully this will be a lot more this year. It's the, as I said, I should have said not small practices. Baby, you got to keep me straight. I should have said that it's the last year they're paying out that additional exceptional performance bonus. And so my goodness, I hope we can take advantage of it this year. And I hope that it's a good one this year. So, so it's worth trying for, but not at the risk of failing. The next level, 75.01 to 88.99, this is the positive adjustment area. You'll get a positive adjustment somewhere between, I guess, 0.01 and 9%. It won't be 9%, but we're hoping it'll get up over 2%. I think 1 year we got up over 2. I don't think we've ever reached a 3, even for exceptional. I'm pretty sure I've never seen a 3 as it for even the exceptional performer. So hopefully we're going to get it up there to 3 this year, and that would be great and a great reward for people who are doing the hard work. 75 points is neutral. no adjustment. 18.76 to 74.99 is a sliding scale adjustment up to -9. Of course, that's not so. It really won't hit -9 until you get to that 0 to 18.75. And then it'll totally be a -9. So if you don't do anything, you're going to get a -9. If you only submitted 6 quality measures that had scores of benchmarks of 3 points each, you would get a -9. Okay. We don't want that to happen to you. We can help that from happening. We don't know that we can get you to exceptional or even passing, but we can definitely get you to more points. My point there was consider the impact of this, because we're going to talk about some exceptions that are available to you, and you've got a decision to make. All right, so we talk about our MIPS tips, and we talk about having a checklist. And one of the things Phoebe and I were talking about, and she's mentioned, is that if you have a checklist, then you don't have to go back and wonder what it is that you're thinking about. So we have a very long checklist that we've provided most of you, but this is just our general checklist. We'll be glad to share that old checklist with you. Most folks did not actually use all 15 or 16 pages of that. We do have a little bit of a shorter version available to you, but not near as thorough and not as comprehensive for an audit. So, but either available if you'd like them. So what do you want to do? You want to go back and review that final rule fact sheet. If you never read it, then just go read somebody's summary. Okay. There's all kinds, the American Medical Association, every specialty professional group. I think almost every one of them has a summary about the final rule and how it affects your specialty. So just get some perspective, read that. Keep your Harp account active. You have to reset your password every 60 days. And I got to tell you, folks, I've seen people have to reset their password sooner than that. So I don't know quite what's going on, but it will go on active if left attended for 6 months. So don't let it go inactive. Having to reset it, yes, is a pain, but not like having to get it activated again. So don't let it go inactive. And please go in and check your previous scores. If something's not right, then call the QPP support line and ask them what you should do. And then call us or email us and let us know what they said. Check your eligibility. Remember, eligibility gets updated multiple times during the year. If it doesn't, if what you check doesn't agree with what you're seeing on the QPP, or what you think is not what you're seeing on QPP, when you sign in and check that, then you need to go to PAYCOS or the MPES system and correct it. All right. Now, could it be something you did 3 months ago and it hasn't been processed? Absolutely. Absolutely. As a matter of fact, I wouldn't even call about it if it was only 3 months old. But if it's 6 months or older, then yeah, I'd call the QPP support line and ask them if they can help what's going on. They'll probably make you call PAYCOS or MPES, but that's okay. Sometimes they'll transfer you and that gets you in a lot faster. So that's okay. Determine if you're going to report individually or in a group. The way we recommend you do this changes from time to time. So this is something you want to consider. And you can change your mind at the end of the year. And regardless of what you decide, even if you decide to report as a group, you need to check your scores individually, because you make corrections to quality and to promoting interoperability components individually at the individual level typically. Okay, so I got a lot of folks that'll show me their group scorecard, and that's not a way to work through a solution. Okay, that just shows me you got trouble. So
That's a great tip, Liz. A great tip.
You gotta look at the individual scores. If you're an ACO, you need to find out what your ACO requirements are. I was just speaking to someone late last week, and we had been waiting for them to have a meeting with their ACO, and they did. And so I was interested in what the biggest changes were. And what they recalled as the biggest changes were, they were asked to do better on and step up their well checks, and they were asked to start doing depression screening, because those were two of the quality measures that the ACO now needed to do, and they needed to do better on it. And this is a practice that had done very good in the past.
Can I ask this might be a terrible question, but do they mean the annual wellness visit when they say well check, or do they actually mean a well check?
Well, I think the answer is yes, they wanted to do annual wellness visits, but they were in particular not doing their Medicare well checks.
Uh-huh.
Okay, so, and I think they were thinking and they had a large Medicare population, and I think the ACO was thinking if the practice would make sure they did all those and be proactive about getting patients in for those, they could impact some numbers. But yeah, but you're right, the annual wellness check, those will both accomplish getting answers to a lot of quality questions. Both of them. Okay, so good point. So they were a little surprised about that. And within the week, they'd already implemented the workflow to make sure that happened. And I've had practices that were specialists start doing the depression screening and the fall risk screening. So they would have something they could get some good scores on with quality. So something to think about. You need to make sure you review each of your components and make a plan to succeed. If you say, I'm just going to we'll work on those in September, that's not a successful plan. You need to say, okay, in the month of July, we're going to figure out what in the heck is wrong with this quality measure for fall risk. Okay. And we're also going to figure out how to get our HIE to start tracking. Our Health Information Exchange Measure 1 to start tracking, right? I have a practice that just in the last week, after 3 months of working hard, finally was successful with those two things. And their score jumped from 0 on the HIE. Well, we finally looked at it. So anyway, we need to be diligent and we need to be flexible, and we'll talk a little bit more about that. You need to make sure you monitor your measures and adjust your workflows. Don't argue about whether you're doing it or not. Check it. I have to tell you, folks, I have people that all the time, weekly, tell me, oh, everybody's doing this just the way they're supposed to do it. And I have to tell you that 95% of the time, they are not within the EHR. I know that seems very high, and it is. But the EHR folks have about got this figured out. And so 95% of the time, it's not a problem with the EHR, other than it may be awkward and bulky to do and hard to remember. It probably really works right if you use the exact workflow the EHR states. So just want to share that with you. And we've been able to prove it time and time again. It may take 2 or 3 months, but you can do it. You want to encourage participation amongst all the practice. Everybody needs to share in the success, and everybody needs to share in the responsibility. The front desk has to deal with getting information that's pertinent to your success, such as the email address for the portal information, just as the person in billing needs to code to the highest level of specificity to get the best cost score. So everybody, we know the clinical is a super big part of it. Everybody's got a part in this. Let them share the success and the responsibility. Document everything in duplicate and save it. And I had somebody just recently, we were going through some SAFER guides, and they said, yeah, we've got a backup. And and I said, what kind of backup? Well, it's a tape. Okay, so how do you keep the tape safe? Well, we take it home every day. The doctor takes it home. And so we went through this cycle of how that's not the best solution, because there's not a duplicate of the backup. So when the doctor's not at home, the tape is back at the office. So it goes back and forth every day. So we went through and worked up a process. So they left one at home all the time, but once a week they recycled. They recycled the weekly tape. So they always had at least only 1 week back for a backup. And that was within the SAFER guide. recommendations. But we had to go through quite a process to get there to answer one little question. So document, keep your evidence, get some help if you don't understand, and keep this to evidence. We like to say 7 years. It's 6+ years, but we say 7 years. That means there's no plussing in there. Make sure you complete your 90 measures as soon as you can, so you don't have to worry about those. You're not stressing in December about your patient portal numbers. And we do recommend, if possible, that you investigate joining an ACO. That's what CMS would like everybody to do. ACOs have proven to do an outstanding job of improving the quality of care. I think they're about to have to jump through some additional hoops, perhaps around health equity or social determinants of health, but I believe they'll do it. And they help practices be more successful in improving the level of quality of care they're providing. So check out an ACO if you can. Now I'm going to just briefly go over these components, and as usual, I'm taking too much time, and I want to do to make sure I get to the highlights and the frequently asked questions. So just wanted to go over the weights of any of the categories. Quality and cost per regulation are now the same weight, 30% apiece. That's 30% for cost, which is a measure. I call it the ghost measure, right? Because we never see it. It's like once you finally get your scores, that's Halloween. That's when you get to see the ghost and you see your score. That's a little bit late to do anything about it. So the cost score concerns me, and it's at 30%. And we're going to talk a little bit more about that. Improvement activities at 15%. Boy, I'd love to see them at 30%. Promoting interoperability. I'd even love to see promoting interoperability at 30%. Those first two, wow, those first two get us. So what you have to think about is these are the 4 components. They're pretty much the same you've been looking at for several years. Should you reweight any categories? Should you try to take an exclusion? Now, I'm going to talk about this in a couple of areas, ways, and this is really probably the most important part of today's session. Small practices will get an automatic reweighting of promoting interoperability. And this sounds like a great idea, automatic reweighting. I'm going to show you in a minute why it's not perhaps such a great idea for your practice. Most practices they just really do a good job with promoting interoperability. It's probably the next to the least one you'd want to get reweighted. But because there are issues with EHRs keeping up with the rules, CMS is trying to give everybody a break, and they've given small practices this automatic reweighting. I will tell most of the practices I work with not to use it. Not all, but most of them. All right. Now it applies to practices with 15 or fewer providers. You can override this by reporting your PI data. In other words, you can just not worry about it. And when we get ready to submit your data in the late winter or spring, actually, whatever, you can override it by reporting your PI data. You don't have to do anything to get the automatic reweighting. As a matter of fact, should you do anything, you're liable to mess up the automatic reweighting. So that's the only bad part about this. You really need to be careful not to mess up what's in there. Most of you should report the PI because it's your best opportunity. It's your opportunity to get the highest score points for a category. It's way easier to get all 25 promoted interoperability points than it is to get all 30 of your quality points. So all 30 of the quality points are actually it's 60, but 30% of your quality reports. So don't just throw in the towel on this one, because I don't think most of you should take it. And remember, if you or your vendor or a registry that you're connected with report your PI, it's going to override the reweighting. So you need to make sure that whoever you work with knows what you're doing and what you want to do. All right. So it's automatically going to happen unless you report you're promoting interoperability. Now, this has nothing to do with another opportunity, and that's your promoting interoperability hardship exception. Now, this is really for those who aren't small practices. These are for those folks that are 16 and larger practices. Because everybody that's 15 and fewer providers, they get the automatic exception, so they don't have to worry about it. But if you're larger practice, then you can get a promoting interoperability hardship exception, and that's available now. It's not available to APM entities, so you need to be aware of that. Hardship exceptions are available for specific reasons, because you have decertified EHR technology that was out of your control, and you'll have to prove it. You had insufficient internet connectivity. This is usually proven at the state level. There are certain areas that are determined to have low internet connectivity. Just because you have a little flip in it, like I did earlier, that doesn't count. You have to be in one of those areas that have been designated as low internet connectivity areas. And that's really not up for argument. Been there. If you face extreme and uncontrollable circumstances, such as a disaster, the practice is closed, severe financial distress, severe vendor issues, and those are hard to prove. But if you've had a hurricane or a fire or some of these things, if you lack control over the availability of your cert, such that you work for a clinic and the clinic won't submit and they won't give you access to your EHR data, that would probably get you a promoting interoperability hardship exception. Please note that just because you don't have an EHR, that is not a reason for a hardship exception. That's a hard no. Just because you don't have, not having an EHR is not cause for getting a hardship exception. They will not give it to you. It's not legit. If you're already exempt from submitting promoting interoperability data because you're a small practice or because you filled out what I'm going to talk about next, you don't need this. And here comes, oh, I'm not quite there yet. I think I went backwards. There we go. So please remember that when you take this exception or this exclusion for promoting interoperability, you don't just get 25 free points. Your 25 points gets reweighted to other categories. So that 30% quality now gets bumped up to 40. Cost stays the same. Improvement activities bumps to 30. And that, I like that. That's pretty good. But again, quality is hard to get a high score for, and cost, I got no clue what it's going to be. All right. Now, a lot of you might not have a cost score because you're in a specialty and none of the cost measures apply to you. So you can tell that by what occurred in the past typically. However, most of you didn't get scores in the past 2 years, so we don't have a reference for this. So it could happen to you. But if both cost and promoting interoperability are reweighted because you took the exclusion and cost got reweighted because you didn't have enough cost measures, then quality is worth 50 and improvement activities is worth 50. That is a scary situation there. Scary, scary, scary. You got to think about these things, folks. It's not just a simple, oh, I'm going to take that because it's available situation. Now, let's talk about another situation that is available. And I've been a little negative about this with folks for the past 6 months, and now I think I'm changing my tune. You have an extreme and uncontrollable circumstance exception that is available for 2022, and it's available now. And it includes the COVID-19 hardship. It's not an automatic like you had last year. Again, it is not automatic. You must apply for it. But if you feel like this applies to you, then use it. I was concerned earlier that you might be required to prove that you were impacted by the COVID-19 situation or pandemic. And I've now seen that the way that you can justify this isn't just by data measures, data from your quality measures. If your practice has been suffering because somebody has been out, as they call it, on COVID vacation, every week another staff member is out because they've tested positive to COVID, or they have a family member that's tested positive to COVID, or they've had a death in the family. I have to say that a large portion of the practices that I work with are having extreme staffing issues, either because their folks left at the pandemic and we can't hire people back, or they've got somebody out ill all the time and they just can't keep up. That's a hardship.
I have to amen that, Liz. I've found the same thing in practices. Staffing is their hugest stress point right now.
Yeah, and I'm ashamed that I was so hard on folks about not taking this because I didn't feel like they'd be able to justify it. But I've changed my perspective on this, and I'm glad I can share it. If you've had a lot of staffing issues, then in my opinion, you can. Almost everyone I've talked to, everyone I have talked to has been able to justify a hardship exception if they so choose to do that. That doesn't mean all of them took it, but it means you need to consider it and you need to discuss it. And remember, if you get the extreme and uncontrollable circumstances and you want to keep it, don't enter anything. Because if you do, it'll wipe it out. Also, I need to call your attention to something that I've heard occurred last year. If you take the extreme and uncontrollable circumstance, if you take it and say, you take it for quality, you asked to exclude quality and cost. All right. You could handle promoting interoperability, you could handle improvement activities, but because of the hardship, you couldn't be successful in quality and cost. And they gave it to you. And unbeknownst to you, your biller was coding, still using the old PQRS codes. I think they're the level 1 codes, was still using those codes on your claims. Those codes would be processed for quality measures and they would be reported, and your extreme and uncontrollable circumstance exception would be wiped out. And this happened to a lot of practices last year, none that I know that we worked with, but I've just heard recently that it did happen to a large number of people who didn't realize that they were still putting old codes on their claims. These could be Z codes, they could be G codes. Can't get in that conversation right now. When I say you need to be sure, I mean you need to be 100% sure, because that would be a negative. If you don't try to attest to anything, you get the extreme and uncontrollable circumstance exception, and you want it to stay just like that, you want to get a neutral, and then claims-based measures come in, it won't matter. They know not to count those. But if you do anything else in there, if you fill in for any other component, the system thinks you want to participate and it wipes out your exception. Whew. Okay, I know that took a long time, but I need to get that clear. So let's see if there's any other things that we want to make sure that we get covered in the next 20 minutes. You want to make sure your vendor knows what you're doing, and you do want to document your justification, even if it's 2 sentences. Just put down in writing why you felt it was justified, just for your information for the future. Now, this is a document that I hope folks will get a copy of and will pay attention to, because this shows you how things get reweighted. Okay. And you don't want something that reweights quality to 70%. Okay. Or most of you don't. want something that reweights quality 70%, because that's an awful high weighting on something that's very hard to score high on. Okay. Contrarily, improvement activities in promoting interoperability are more easily controlled, and 9 out of 10 times we can fix you in promoting interoperability if you give us 90 days, a running start, 90 days to do it. Okay. If you have an EHR, all these caveats, right? But we can fix those. Quality is a whole different story. You may be doing a beautiful job on quality, but the quality measures you're doing are topped out, and the most you can get is 3 points for them. There's nothing we can do about that. Your best measures may not be available on your EHR. If you can't afford to use a registry and get access to those measures, there's nothing we can do about that. But we're going to try everything we know. But this is an excellent reference piece. And you might look at this and say, oh my goodness, I want that one that's 85-15 improvement activities and promoting interoperability. And I've seen people get extreme and uncontrollable circumstances and get that very thing. But that's the one you got to make sure there's no claims quality data coming in. I love this slide. Okay. Now, this is just some general information. I'm not really, because of time, I'm not going to go through each and every one of them. They're just the recap of what you need to make sure you do for quality. Okay. You need to remember it's for a 12-month reporting period, and you need to find your 6 best measures, because we don't get all the extra credits that we were getting anymore. So you need to find 6 measures you can do a good job on that have benchmarks that you can reach high points with. And that is hard to do. You may need to go to measures that don't really make sense to you, but you can do, like depression screening. That's a good thing. Everybody needs the depression screening, even if you are an ophthalmologist. Fall risk. Once I talked to otolaryngologist into doing fall risk screening, he finally agreed that it was a handy thing for his type of practice. So consider some things a little outside of the box, because the box is a little too confining right now. Check that quality report monthly at the individual level. And if you're trying to fix something, check it daily or weekly until you get it fixed. And I have just worked recently in the last few weeks with some folks that have been very tenacious, and they made a difference and they fixed things. But it took a lot of accepting where the problems were and then adjusting the workflows to improve. There are new measures coming, new floors for new measures coming up. So that's good. No more 3-point minimum. Now we can get a 7-point and a 5-point minimum. So that's great. All other measures are still going to have that 3 to 10-point benchmark unless they're topped out. And then we're going to see them, or that there's no benchmark available, which is different than it being a new measure. That's very frustrating. But if for whatever reason, and there are some this year, there's no benchmark available, you only get 3 points. Now, what you're not going to get anymore is your bonus points for extra high outcome and high priority measures. You still have to do at least one of those. Okay, but you don't get any bonus points for doing extras. You don't get any bonus points for end-to-end reporting. Those bonus points are gone. You can still get your small practice bonus of 6 bonus points added at the performance category level. But folks, in one fell swoop, you probably just lost 6 to 10 extra credit points on quality, where we can't afford to lose them. So we need to think of what the best solution here is, and most of it is just troubleshooting and working hard. Now, cost, we can't tell you much on. It's the mystery, or the ghost component. We never know what that score is until after the fact. It is based on multiple measures. They tend to skew towards hospital encounters or surgeries. And they tend to focus around those encounters or those activities. So a lot of folks don't get anybody applied to them for the cost measure. But the problem is we just don't know that until after the fact. You don't do anything to report this, CMS automatically tracks it. And it'd be a wonderful thing if we could automatically check it, but we can't. One year we could, it was really cool, but that went away. I think that was the second year. Here's the most critical thing to take away. Code to the highest level of specificity. Let me say this again. Code to the highest level of specificity. If you don't know what that means, we'll be glad to talk to you about it. Heck, we'll be glad to do a whole section on it. I just had somebody say that I asked them and they talked to their vendor. They were working with their vendor on their measures. I said, did you talk to them about cost? And they said, oh yeah, they gave me some good advice. I said, what'd they say? They said code to the highest level we could. I said, you know, that means code to the highest level of specificity, right? And apparently their vendor said it better than I did. And I was a little disappointed. So I'm gonna make sure it's clear to everybody. If somebody has multiple diagnoses, you need to code to reflect every issue they've got. The higher the risk, the higher the adjustment, the lower the cost. Just that simple. But I got to tell you, we see some big disconnects between what the administrator thinks is happening, what the clinician thinks is happening, and what the biller's doing. And you got to do some work on this one. It requires some detective work to figure out. Now, if you participate in a transition of care scenario or an HIE or with a community of care, then it greatly reduces your cost because everybody's working together, everybody's got their data, and it does control cost better. But if you're not in that environment, you need to take some steps because you do not want to get sideswiped by this one. Improvement activities, they're really the exact same. And the only tips we have to enforce with you is that don't do any extras. If you're a small practice, you need to do 2 mediums or 1 high. Don't do any extras. If you submit any extras just for good measure, you can be audited on them. If you submit 3 and you only needed 2, you can be audited on all 3, and you can be failed based on the 3rd one you didn't need. So don't do that. Please, please don't do that. That's the important thing about this. I did want to give you a list of some things we want you to have for your improvement activities. All, some, just not none. We recommend a project plan. Doesn't have to be sophisticated. It just needs to be. Meeting invitations, emails, agendas, visuals, handouts, screenshots, reports, proof. That's what we recommend. I still think we got a lot of people out there that couldn't even prove what they were going to do last year. So let's get it straight this year, just in case.
And on this one, Liz, I know you've talked about it so many times in the past, having the using what CMS has provided, the validation criteria to make sure, because they now do a much better job of letting you know what documentation will be valid and accept. It's a great guide.
Thank you, Phoebe. You're absolutely right. And we use that validation guide almost daily. And it did have some changes this year. They dropped one of my favorites, but that's the way it works. And that's another thing that I didn't go over is improvement activities change. And if it was easy for you to do, then you rest assured it won't be there in 3 years. Okay. That's not exactly true. I'm being facetious, but it feels like it. So pay attention. Try something new on the improvement activities. I know I'm running out of time. Here we go. Promoting interoperability. Got a couple things I got to point out to you on promoting interoperability. I know I pointed them out before, but I don't know if I was clear. Carefully consider your reweighting, because if you reweight everything to your portal and your portal number is terrible, that's going to be a terrible score. You got to think about it. Auto reweighting can occur for the entire category, and that's what this is talking about. because there is auto reweighting for small practices. Now, the portal is critical. It's the biggest piece of your promoting interoperability. It's critical for the 21st Century Cures Act to ensure that you stay safe within the 21st Century Cures Act. Gosh, it's just critical. And I hear so many excuses about why people have low patient portals numbers, and most of them are not legit. It's just a pain in the rear to figure out what makes it tick. A lot of folks are seeing the 4-day time limit as a problem, so check that out. If your provider's not closing the record and signing off on it in 4 days, you're not getting credit for this. Usually it is the workflow. Some box is not being checked, some piece of data is not in captured. Okay, so work on this one. You can make this one so much better. I'm not buying all my patients are too old. We got an opt-out policy for that. No excuses. Patient portal, fix it now. It's going to come back and bite you if you don't. That was a little strong. You also are supposed to provide information on how to access your patient portal through a mobile app. This is a requirement. It's part of the specification. And most of the vendors will tell you they don't do that. They don't know what you're talking about. If they say that, send them the specification, highlight the requirement, and tell them you need to know, because you have to provide to your patient the information. You can put it in the intro email when they sign up for the portal. You can hand it out when they come to the register to come in. You can hand it when they check out, but it has to have the instructions for accessing the API, accessing the portal through an API or an application programming language, just an interface, and some of the apps, at least one app that works. Third-party open apps. Okay.
Unfortunately, we do have to sometimes help the practice educate the vendor. And
oh my gosh.
we have to, because they really do not know.
This one has
This is a must do.
This one has just been a nightmare with the vendors. They don't know it. Okay. Luckily, we've got a handful of vendors. We've already know the answers, and we'll be glad to give them out. And if you don't know, we'll be glad to get on the phone with you and your vendor and figure it out. But it's the rule. If they are certified, they have to be able to do this. Just because the first, second, third tier support doesn't know, doesn't make it okay, unless they're fraudulent. And we have suggested that to some of the vendors. Either you tell us how to do this because you're certified and it says you have to, or we're going to report you for fraud. Period. End of sentence. That lights a fire up underneath them. Okay. I wanted to spend a lot of time on health information exchange, and I don't have time to do that. But this is what I got to say. Call us. Let us help you with health information exchange. You've got to start doing this. You wouldn't believe what the great impact it can have on your quality measures. Health information exchange alone could make your quality measures soar, okay, if it's going right. If you need help with your referring physicians, let us know. We'll help you. You need to make something happen here. If it's going to happen, let's just put you in the front end instead of in the back. Now, I do need to talk about the new requirement for electronic case reporting, because you no longer can just report or exclude on 2 registries. You have to report on immunization registry and electronic case reporting, or ECR, or taking exclusion. And your EHRs must be able to do this. And again, there's a specification for it. But my goodness, your EHRs will declare that they don't have to do this. They don't know what you're talking about. It doesn't exist. All right. Now, the good news is for 2022, you can take an exclusion for this because your EHR isn't ready, just for 2022. But your EHR has to give you something telling you they're not ready. So for them to not acknowledge it as a requirement is a little awkward. They have to do this. It's in the specification. Either they do this or they're fraudulent because they're certified to do it. So they're going to have to do it in 2023 unless something changes. We can sure help you with this ECR. High Bridges, our HIE has some grant money available to help out with this. There are some solutions available, but we got to get your EHR to acknowledge where they are. Okay. There's the specification. We'll be glad to share it for all to see. And you can get extra credit if you're doing something beyond and above those two. 5 points. You can't, if you're doing 2 more above and beyond those 2, you do not get 10 points. 5 points is the max. Let's see. Oh, another new thing that I got to mention before we run out of time is the high priority guide, the high priority guide of the safer guides. Now, the safer guides are new. Well, they're not new, actually. They've been around for, oh my gosh, almost 10 years. They've been around for a while. We just haven't been using this. And CMS has now realized that. So now they're saying we got to do them. It is a new required measure, but it's a little odd, guys. Okay, it is odd. You have to attest that you've completed the high priority practices safer guide. And there's so much wonderful stuff on how to do this. It's lovely. However, you can answer yes, that you did it, or no, that you didn't do it. And that's okay. That's okay. You will still pass. If you don't answer it, you will fail. So if you say, yes, I did it, you will pass and you'll be subject to audit on it. If you say, no, I didn't do it, you'll pass and you won't be subject to audit on it. But if you don't say anything, you will fail the entire promoting interoperability category. Woo! Woo! That is heady. Okay, so think about that. I don't mind if you want to say no. That's reasonable, but at least take a look at this guide and get in there and start using it. Hospitals have to do all 9 of them. You only have to do 1. But I wouldn't be surprised to see it become required next year and or a second one being added. So very similar to security risk assessment. Have fun with it.
And with cybercrime on the rise, you want to do those.
Oh yeah. Oh yeah. It's good stuff, but it's a little boring. Just want to mention that the complex bonus is still there and it's going to stay at 10 points, but it's a little harder to get. I mentioned this to you because 6 points of an HCC added to your final score is pretty important and can help. And it all comes back to that level. It does come back to highest level of specificity. It is worth the effort, but you got to work at it. Okay. Let's get those complex patient bonuses higher. Let's get that cost score better because of our risk factors. Let's do this. If it doesn't make any sense to you, what I'm saying, then let us help you understand it. That's not an excuse. All right, I'm not going to go back over these because we've talked about them. I probably beat them up too much. And the frequently asked questions are things that we have talked about. One of the things I want to point out is there is a link to the safer guides, and it gives you everything you need to complete the safer guides. It's just a beautiful thing. You can download it. I'm recommending folks they put it on the shared drive. In a cloud shared drive, and just make sure you use a version number every time somebody updates it, and have the people that need to participate, maybe have a little training session on it, and then share the work on it. It's a lovely, lovely thing. I do want to say that the MIPs, the changes to MIPs, we went over all of them, probably ad nauseum, but they are available for you. They're in the final rule. They're in the resource center. But you need, the net of it is you need to work with your vendor on every nuance of the workflow for every measure. Okay, because sometimes looking in the wrong corner will fail a measure. Okay, so it's just amazing. Oh my gosh, I wanted to talk about transition of care for so long, but it's about continuity of care and working as a community. And so we'll talk about that on another time. And Phoebe, I think that's all we've got time for.
I think you are correct. We really appreciate those tips because it can make such a difference. And if anyone would like the recording, can you scroll down to our contact slide so that they'll know exactly how to reach out to either one of us? And we would be happy to provide you with the recording when it is available, because we really want you to have access to this information so that you can be successful this year and into the future. So Liz, thank you so much for the wonderful way in which you consolidate this vast array of information and presented it to us in a way that was action oriented. So thank you all for attending and have a fabulous, safe afternoon.